it's a great pleasure to be able to introduce Dr. Alan Zuckerman today to give our last talk of the evening. So Dr. Zuckerman is a trained pediatrician as well as a faculty member at Georgetown University and highly regarded for his work leading the discussion around medical informatics and the developments in that field. So with that, I'll leave you with Dr. Zuckerman.
Thank you. It's a great pleasure to be down at your regional consortium meeting, which is the first time I'm actually at one of the local regions where I hope to have opportunity to interact with as many of you from the individual states as possible to try to learn more about your programs. I hope that we'll be able to engage in somewhat of a dialogue. At the moment, I spend the majority of my time at the Lister Hill National Center for Biomedical Communications at NLM, and also with HRSA at their Maternal and Child Health Bureau, trying to work on the transformation of newborn screening into the electronic age and lay some of the foundation. But I am continuing some of my practice activities. I want to start by thanking our large team at NLM who developed the newborn screening codes website that I hope, if those of you who haven't gone to it yet, will go to it after this talk and begin using it on a regular basis, and some of our many other collaborators who are working with us. And we've just established a Health Information Technology work group as part of the Secretary's Advisory Committee on Heritable Disorders in Newborns and Children, where a lot of our efforts are going to continue to expand and standardize the language of newborn screening and encourage its use in population health evaluation. What I hope to talk about today is not so much the methods and the codes, but more the environment and the reasons why it is so timely to begin working on standardizing languages. This is going to enable many new types of activities in data exchange and sharing, taking what has previously been done manually to new levels. And the initial newborn screening report is the backbone of all language standardization. And there's guidance out from NLM and HRSA that's a useful resource, but we have to get people at the states to begin to apply and use this guidance to bring our initial newborn screening reports to a uniform level across the states. The follow-up of newborn screening depends in many ways on standard language to be able to make comparisons between different regions, between different disorders. Last week, the final regulations came out for meaningful use of EHR incentives, and these deal heavily with language standardization, and the opportunities to include newborn screening in these activities are going to become more and more apparent in the years ahead. But I think the area of greatest concern is that of quality measures for newborn screening. And in order to implement quality measures and use quality improvement, quality accountability is going to depend on having standard language to locate the information, to report the information in uniform ways. And again, my most important agenda here is to open a dialogue with the Southeast region to try to use this area as an important model for the rest of the country for trying to standardize language, standardize coding, and document where we stand today in moving into the use of informatics standards. So as I said, the standardization of languages and codes is part of the process of enabling new forms of data sharing. And you've heard about several of these many times throughout the afternoon. But every state newborn screening program is different. And the goal of standardizing language is not to change the individual state programs. Instead, it's to accurately document what the individual states are doing and enable them to communicate with each other and share their data. One of the first situations where this comes up is in clinical care of patients, particularly the border patients receiving care in other locations, and especially those neonates who walk into emergency rooms and should have their newborn screening tests checked to avoid confusion with other disorders. And these emergency situations and travel situations can occur in locations other than where the testing took place. And this is a reason why the ability to communicate those initial reports will be so important. Another area that this region has taken the lead on is disaster preparedness. If we can understand better how we report our data, it will be easier for other states to provide regular backup and mirroring. We already have a network of some states providing services for other states, and ultimately we should be able to move towards a level where data becomes portable without necessarily forcing individual states to change what they do or what they report, but to understand accurately what they have been doing. And the final area that I think is really breaking through and that you've seen and have begun to use here is the new knowledge discovery that comes when looking at populations. And I'm pleased to hear that all the states here are participating in the Region 4 MSMS project, which is now going to be expanding into several other areas of data, including potentially the emerging lysosomal storage disorders, some of the new tests, better look at hemoglobinopathies, and even the endocrine disorders. The standard terminology, whether it's as obvious on the front or not, has been a critical factor in building those databases of confirmed cases. But there's another side of better understanding the population and cutoff data that contributes to the confirmed cases and some of the state-to-state variation that's also going to need work. And many people believe that the use of standard codes doesn't apply to them because they're not using electronic health records. They don't have control over their own information systems because there are constraints in state budget. But in fact, the use of standard language and codes is not limited to those people who are using systems immediately. Because you can still benefit from those codes by applying them to your paper reports and to standardize the language with which you communicate by any means of communication. Also, there are a number of intermediaries and a number of different strategies that are being evaluated in different parts of the country. Coded messages coming from a laboratory can go to a web portal and expose the data in a broader form. In some states, it's the labs that are able to generate the standardized messages, including the codes. In others, the labs have their own internal formats, and it's the health departments or the newborn screening programs that need to insert the codes and language that enable the data to be shared in more uniform ways on web portals. And those web portals will again be very important in exposing data to broader audiences, both within states and between states. Health information exchanges are beginning to move from a state of potential to actual operations in many parts of the country. There are several in the Southeast region in different states of implementation. And slowly, newborn screening is becoming one of the activities that information exchanges can engage in. But as we're discovering in some other areas, such as in Indiana or in Massachusetts or Pennsylvania, the health information exchange can play new roles that can transfer the responsibility for information technology into new hands. A single message sent from the newborn screening program can then be adapted at the health information exchange to reach a wide variety of hospitals through different communication forms. It can send data directly into primary care electronic medical records or expose the data to a large number of primary care physicians through web portals. It can also help to locate who the primary care physician for a particular infant might be. And in some cases can even build some of the bridges with vital records to assure that all children have been screened and have been found. So the use of standard language to enable communication with health information exchanges is something that we should begin to focus on. Another area that newborn screening distinguishes itself in is to move away from this immediate focus on the newborn period into a lifelong focus. It's extremely important we begin to document results in the medical record. And you heard earlier today about the issue of sickle cell trait and sickle cell screening, kind of information that should be moving to families and to patients throughout their lives, and it should move with patients as they get older. There are a number of other situations in which data may be of value when transferred after the immediate newborn period. Risk factors also may mandate rescreening or periodic screening, and documentation of these risk factors will, in the electronic medical record and a lifetime view, can enable new information. Most newborn screening focuses on the newborn hearing and on the dry blood spot. But in fact, there may be opportunities to use family health history data, various types of carrier screening and prenatal testing that should be integrated with newborn screening. And when we can document both the newborn screening and these additional data sources, they can be brought together. So what we do today to standardize the description of what we're testing today and what we learn today is going to govern a great deal about what we're able to learn about newborn screening in the future. So as I said, the laboratory report is in fact the backbone of all coding. And the guidance that's available at the Newborn Screening Codes website at nlm.nih.gov is an ongoing process of accommodating variations for different states and integrating into it new tests as they emerge, and eventually confirmatory tests will be added as well. Some states talk about acyl-carnitine, some talk about fatty acid oxidation disorders, and these variations can be accommodated along with quantitative reports by analyte paired with interpretation comments or reports against the initial panel of conditions. A comprehensive screening report can serve the needs of many different providers and many different groups and can be filtered so that data is hidden when reporting normals to primary care clinicians so as not to overload data. But a comprehensive baseline report will provide the ability to do more population analysis in the future. And again, at the site, you're able to download information or to look at the individual HL7 panel or bring up information about code standards or about the conditions and mapping between different disorders. And the report allows summary descriptions and lists of specific conditions with positive or equivocal markers, as well as lists of all tests that have been conducted. And each of the analytes which people are currently looking at have their own line codes to have uniform ways in which these initial reports can be searched if this data is coming out of the laboratories. And interpretation fields are paired with particular conditions so that these can eventually be extracted from the databases to provide instructions and care, which provides a much more reliable way of retrieving data and comparing data across states or across patients than would happen if this data simply goes into free text nodes on a report, as has been the practice in the past, particularly with paper. And there are many ways to code conditions, and those answer lists provide a standardized way of identifying conditions through standard codes that are going to be uniform across the different states. But what's put on the laboratory report also has to be mapped to what gets into the problem list in the patient's medical record. And this is where the diagnostic coding systems, such as SNOMED CT, help to identify the clinical conditions and their various variants and subtypes, which have been mapped to the target conditions in these coding tables. For some of the conditions, there are specific enzyme codes, and eventually there may be linkages to specific genetic testing data that's also available. So it's important to capture the quantitative measurements that uniquely identify the condition and its variants, as well as to correctly name and count conditions through standard codes. And the line codes, which are used on the lab tests, and why rhymes with oink, just like a pig, creates a bucket, a place to put numbers, and those numbers can be numeric values or they can be coded responses chosen from lists. And they're very specific to separate out measurements that are done on a dry blood spot from those done on whole blood, those that are done by different analytical methods, and those that produce different levels of quantitative precision. SNOMED CT, on the other hand, is a system for naming diseases. And there are growing opportunities to get the kinds of conditions, newborn screening and some of the related genetic conditions, fully documented and described within SNOMED as this becomes a standard code system for clinical problem lists. The International Classification of Diseases, on the other hand, are classifications that create broad buckets which lump together many different disorders, such as all amino acid disorders, and are useful for billing and useful for certain other public health reporting because everything has a place, but it doesn't provide the ability to generate the kinds of cohorts we're going to need for follow-up and for quality measurements. And of course, effective follow-up is going to depend on those standard codes to identify the population. As you've been hearing, there are really three different components to follow-up, and each one has its foundation in having a standard language to identify what has been done for an infant. The first area is completion of the population coverage based on comparing birth records to various protocols for completing adequate screening specimens, the approaches to second specimens, and to the handling of premature infant. Short-term follow-up basically begins with an out-of-range data on an initial screening and ends with a confirmed case report or eventually returning the infant to a normal pool. And completion of that short-term process is something we'd like very much to track and understand better. But we need to be able to clearly describe who's engaged in that process. Long-term follow-up begins with the confirmed cases and is going to be an effort to get outcomes and interval assessments. And because of the limited numbers of confirmed cases, it's going to be very important to standardize our description of the cases so we can pool data from different areas. At the advisory committee nationally, a lot of work led by Dr. Kemper and others have tried to define some of the overarching questions for effective follow-up. And while we've made a lot of progress in defining questions, coming up with precise ways of answering these questions in valid and reproducible ways is a challenge. For example, care coordination through a medical home is going to require some way to examine a record, preferably an electronic record that can be scanned quickly in large quantity to determine if, in fact, care coordination is going on for a group of infants with special needs. Evidence-based treatment has similar condition-specific requirements to be able to describe whether that treatment has in fact occurred. And beginning to build the vocabulary for these treatments is going to be extremely important. Continuous quality improvement involves having indicator measurements to determine if we're making progress. And when we look at something like medical foods, this may be a very interesting area in which we can track the number of infants who were originally allocated to a food program from those who are continuing to receive them, and to develop feedback programs to find those who are falling out. And new knowledge discovery involves getting patients into various clinical trials and other case history studies, again, based on what we know about the conditions. So if we can't develop precise language and codes within electronic systems, it's going to be very hard to implement these kinds of goals by manual chart review, which is very difficult and time-consuming, and will compete poorly with other areas of medical knowledge and progress in which electronic approaches to answering these questions are being developed. Within the long-term follow-up area, a number of uniform data sets are being developed to help build comparisons. And as you've heard, within the Translational Research Network, we're getting very close to having definitions of core and condition-specific measures that we'd like to apply and collect on a long-term basis. But the next step there is to develop language and codes to get the data into clinical records and to move away as much as possible from having duplicate parallel record systems. Ideally, the systems which are used for clinical care should be generating these long-term measures so that they can be extracted, or if they're not being generated, so people can be prompted. We've seen a great deal of success of this in the area of cancer databases and in the cancer networks, and some of those same information technology approaches that have been used in other diseases are now ready to be redeployed for newborn screening. Again, within the follow-up area, one of the most interesting parts are the clinical and genetic variations. And our ability to define clear cohorts of different clinical variations and subtypes may begin to depend on genetic testing and adequate descriptions. And at the National Center for Biomedical Informatics, NCBI, a number of coding systems have been developed to describe different gene loci, sequence variants, and methods of recording those. And we're getting very close to being able to release new standards and codes that may approach what we've achieved on the ability to describe initial screening, will enable us to capture and preserve genetic testing when this has been done. And it's had great successes in the area of pharmacogenetics, and hopefully in the next few years we'll be able to apply it to newborn screening. And again, genetic testing may in time become a very important part of second-tier testing to begin to refine and confirm cases more clearly. The ARA and HITECH, the Recovery Act, has now finally yielded its final regulations last week and is about to begin the first of 3 phases, and the details will continue to evolve. I'm not going to try to present all of that, but want to get you to think in terms of how newborn screening can exploit this effort to bring electronic records into new environments. There are essentially 2 pieces to meaningful use. One is the certification criteria that define what an electronic health record that vendors are trying to sell is going to contain, what you can expect, and how this will be tested. The other side are the measures of meaningful use that apply to the user of the EHR. This is the data that they're going to have to turn in to show that they're actually using the capabilities that are inherent in the system that they've purchased. And we've moved into a very interesting first phase approach, which is going to separate things into core and what are now being called venue items. The systems you buy will have to include all of the functions on both lists, and eventually everyone is supposed to move in the same direction. But the initial years, users will be able to selectively pick a few items that they're going to do and others that they may delay. Also, there are going to be performance levels so that you may not use the capabilities of electronic systems for everyone. In the case of lab systems, they're looking for a 40% use of the integration of lab tests as discrete data, so you can actually find the newborn screening results if they're being sent to standard formats within the primary care and hospital records. And some of the criteria will allow some alternate standards, but eventually we're anticipating things to evolve so that you won't have to rely on customized systems. The capabilities will be there. And some of the most significant changes that are coming is that things like problem lists will need to be coded and standardized, so we will be able to find cohorts of cases. The loin codes and the lab results will slowly be added by the labs, but if you receive one, you're now going to be obligated to retain it and pass it on to others. So this will enable more accurate transfer of newborn screening data between providers. And reporting to public health is a very important part of these meaningful use requirements. And there's going to be an effort to ramp this up and to get standardized reporting, because what I repeatedly hear is that many health departments don't get enough data back from the primary care providers, don't necessarily know the outcomes of all the confirmatory testing. And another new dimension is the focus on consumer involvement. And the way to see many of this is through 6 key functions that are part of the objectives in this initial program. One is to maintain an up-to-date problem list. Another is to incorporate lab results. Well, these are the more familiar things. But the new things that are coming in are sending quality measures to CMS or to the states. And quality measures based on newborn screening may be an ideal example that physicians can choose from. The ability to generate lists of patients by specific conditions is the practice registry part of the medical home. Sending reminders to patients for preventive and follow-up care may enable us to get retesting for hemoglobinopathies at 6 months, to get a better performance on hearing data, and even to get more routine long-term follow-up on a wide range of conditions. But what's really new is the issue of providing patients with timely electronic access to their health information. The fact that parents will eventually be able to request newborn screening results and get additional data. And again, quality measures are going to be an important part of making this happen. Not only is it part of health reform, but it's very specifically listed in the Newborn Screening Saves Lives Act. And so we're under a legislative mandate to develop quality measures to review that newborn screening is working and is being carried out. And this depends on being able to define measures that preferably can be carried out electronically. And the definition of the measures is one file. The location of the data within electronic health records and within state hearing or metabolic screening follow-up systems is the source of the data. And from this, one needs to generate a report that can be sent on to state review agencies or nationally to show that a measure has been captured on individual patients, practices, or populations. And the National Quality Forum is reviewing and endorsing these projects, and in particular is insisting on documentation of importance, opportunities for improvement, documentation of the reliability of the data. Can we accurately find out if infants are getting their metabolic formulas and the like? And one of our biggest challenges the next 2 years is going to be to try to measure up to the standards set by the National Quality Forum in other diseases in newborn screening to prove that having quality measures is important and has the ability to have impact on what we can achieve. So lastly, I wanted to get us thinking about what we can learn and document on the state of affairs in the 8 states here. And I'm extremely anxious to converse with any of you willing to grab me. I'll be here through lunch tomorrow. And for example, I have copies of the filter paper cards from each of the states and would love to find out if in fact these are the cards that are being used, who's filling them out, what data you're getting or not getting, and if we have opportunities to build more uniformity of what's collected on the initial forms, and even to move eventually to improve the quality of that data so that we can better evaluate risk factors and other data that can be combined with the screening results. Another area to look at is the reports themselves, and to find out how close we are to beginning to insert the codes in messages, and if we're not there yet, to begin to map on paper the codes and terms that we could be using with the reports currently being generated. I'm extremely anxious to find out what quality assurance programs might be in place in this area and what people are thinking of doing, how we're approaching looking at timely review of newborn screening. In the area of cystic fibrosis, which is a relatively new test, what's being done to compare diagnosis through newborn screening to data on infants who were picked up clinically at older ages, and find other ideas. And finally, I'd like to find out more about participation in the Region 4 project, how data is getting there, and the level of interest in the expansion of this project to cover some of the new disorders. And of course, more information about health information exchanges will be appreciated. I'll just move quickly through the conclusions. Again, the most important for me is that this region could become an opportunity to learn more about what can be done to standardize language and improve data sharing. And again, very eager to hear from you after the meeting and to continue to learn more about the individual state programs. So thank you for a long day, but I think a very exciting day. And I'd love to take some questions or get some feedback on the ability to connect with the areas that I've raised in quality and follow-up and meaningful use. And although everyone talks about their limited resources, the use of codes and standard language is going to enable us to get the evidence, to get more resources in the future.
Is there any questions for Dr. Zuckerman?
I'd like to ask a question about the presentation by South Carolina where it was clear that restrictions on the data were interfering with the development of these types of homogeneous data systems. How is that going to be addressed at a federal level so that the idea of individual autonomy and confidentiality really doesn't trump this whole activity?
The whole area of privacy policies is really quite central to enabling health information exchange. And federal policies are definitely not going to trump the state policies. But some federal guidance may be helpful. But even more helpful may be guidance from other states. And one of the effective follow-up grants out in the state of Utah has been working hard on privacy policies, and several of the other groups around the country are trying to articulate these. And more opportunity to share these and to give examples of states that have been successful and that have either made changes in their legislative constraints or in their data systems to work around things may be helpful. I think the most important part of privacy is that it has to be our number one area of respecting consumer preferences. As we've learned with the residual dried blood spot, it's an enormous mistake not to take this into account and not to disclose our policies. The Genetic Alliance, through its clearinghouse, is also trying to assemble information, and we just brought in some privacy expertise to our health information technology work group at the advisory committee. So this is going to continue to evolve. But I think the more important lesson from that presentation today is that barriers to getting access to systems are really going to prevent them from working. And this idea of the background check to get an initial code is similar to various things we've seen with immunization systems, with many other things. Ideally, we need to tie access to newborn screening to medical licensure and to see what can be done to get all licensed providers access. Even more important is how we're going to build a national network of trust so that newborn screening programs in different states can vouch for physicians who have access to their own data and send their requests for data to another state automatically, not to work with the I practice in 3 states around DC, and it can take us 2 or 3 days to get calls back from adjacent states and to identify ourselves. These are things that if we're in an emergency room should be possible to overcome. So there are no perfect answers, but I think we need to share our data and begin to think more creatively about how we can make this happen, because it is the first priority in setting up electronic exchange of data, particularly for providers. And getting consent from parents initially in the birth facility may be a key step along the way, that they can authorize providers to have access to their data. In fact, is there anything going on in this region in privacy policy development that may be worth sharing?
Are there any efforts to develop codes for family history also?
For what?
Family history? I mean, current state,
Yeah.
none of the electronic medical record systems have coded family history.
Yeah. HL7 has a genomics committee that's developed a very elaborate family history model and methods of very clearly documenting family history of different conditions. And again, the use of the SNOMED codes and use of short lists of areas that have been identified as important family history questions is helpful, but it also provides opportunities to document confirmed cases and genetic testing in other family members and to provide a portable form. The best source of family history is typically going to be the family itself, and the ability to collect things through the Surgeon General's familyhistory.hhs.gov tool and to move this into clinical systems is going to be important. Family history is one of the few things that you can't start over from square one each time you see a new patient. And ideally, projects that are going on with NICHPEG and others to collect family history prenatally and make it available to postnatal providers is going to be a very important source of data in the future.
To answer your question about regional activities, I mean, the RUSH project has already started talking about this in terms of the hemoglobinopathy registry, not the surveillance system, but the registry. And we have 3 states that are participating. And I think the hemoglobins might provide a unique opportunity because of the detection of all the carriers and the ethnic and racial overtones that have been associated with the disease. And so if we could develop strategies to overcome these issues in that area, I think.
It also has provided important evidence of the importance of sharing and making this data available because of the number of cases of sickle cell disease that have occurred in subsequent pregnancies when newborn screening has detected the sickle trait in previous pregnancies. And this, to me, provides a very clear example of the ability to produce improvement in care that has been missed because data hasn't been transferred, hasn't been accessible. And we need to find as many examples as possible of the importance of access to newborn screening data and the opportunities to improve care by improving the process, including access to previous data.
Any additional questions? If not, thank you very much, Dr. Zuckerman. Greatly appreciate it.